Well, good evening and welcome to everyone who is joining us this evening. My name is Dr. Stephanie Myers, and I'm the National Co-Chair of Black Women for Positive Change. And we are very honored this evening to partner with the Preeclampsia Foundation to put this workshop on tonight to talk about a really incredibly important topic that we should all be very concerned about and knowledgeable about, the issue of Black maternal health. And tonight we're going to talk about Black maternal health through a different kind of lens. We're not only going to talk about the health issues affecting it, but we're also going to talk about the importance of advocacy and Black maternal health, and also how violence and nonviolence have to be addressed within the lives of women who are experiencing maternal health issues. This event tonight is part of the 12th annual Month of Nonviolence, Families, Voters' Rights and Opportunities. This is a month that the Black Women for Positive Change Network sponsors every year. And tonight, of course, we'll be focusing on family issues. We've had events around the country during October, this month of nonviolence, families, voters' rights and opportunities. And we have focused on violence prevention, de-escalation, opportunities as alternatives to violence, and a range of other subjects, domestic violence, and other topics that are relevant to so many families, not only in America, but all over the world. It's tragic that we have to look at maternal health through the lens of violence, but you all know, like I know, it happens more often than we think. And we have to stop ignoring it. We have to stop pretending it's not going on, because we know that 70% of the children in the Black community today are being raised in single-family households. Mm-hmm. And so maternal health is even more critical because most of these households are led by women. So we must make sure that our women are healthy and that they are strong, and we can't afford to lose our families and our women to preeclampsia and other diseases. As we look at the issue of violence, we always talk about the death of a child, particularly a male child, means that generations have been erased from the planet. And this is the same case with a preeclampsia death. If we lose a mom, look at what we've lost. The children, the sons, the daughters, and the generations. We can't afford to do that, particularly now when the world is in such crisis. We have to put our arms around our mothers, our arms around our daughters, our sons, and do everything we can to protect them. I'm really looking forward to our discussions this evening. I'm really so grateful to the leadership of Rolanda Hatcher-Gallop and the Preeclampsia Foundation. Our organization is very proud to partner with you. And this evening, we're very honored to be represented by several members of our own network, Dr. Valda Crowder, who's an emergency room physician and a director of an emergency room at a major hospital in Pennsylvania. She's also chair of the Health Committee for Black Women for Positive Change. And we're also joined by attorney and nurse Carthenia Jefferson, who is chair of the Alabama chapter of Black Women for Positive Change and a leader. But you're all leaders tonight, and we know that, and it's just our honor to be with you. We invite you to visit our website at monthofnonviolence.org and click on events, and you may see something you'd like to participate in over this next 2 weeks as October continues to go. So with that, thank you all for being here, and I'd like to hand off to the liaison to our organization, the dynamic Rolanda Hatcher-Gallop. And take it away, Rolanda. Thank you.
Will do. Thank you so much for that great introduction and overview, Dr. Myers. And thank you for championing nonviolence and peace in our country and beyond. Hello, everyone. How y'all doing tonight? Can I get a wave? Thank you very much. Thank you. It is a pleasure to be here with you this evening and to moderate this great event. Our goal with this discussion is to examine Black maternal health through the lens of advocacy and nonviolence. But more importantly, we want to impart ways we can take action to advocate for ourselves and our loved ones. The Preeclampsia Foundation is pleased to partner with the Black Women for Positive Change because, like that organization, we are focused on finding solutions instead of restating problems. The foundation takes an evidence-based, multi-level approach to addressing primarily preeclampsia, as well as other hypertensive disorders of pregnancy and Black maternal health. This webinar is one approach. Another is our Take 10 for Preeclampsia Research Initiative, which aims to amplify Black voices and experiences in preeclampsia research and maternal health. You can find more information on the Take 10 campaign by logging on to www.preeclampsia.org/take10. As for this event, you will hear patient advocates raising their voices along with our invited healthcare providers, community leaders, and other experts. Maternal morbidity and mortality rates have long been higher in the United States than in many other high-income nations. But we can begin to turn the statistics around. We got to do it for ourselves, for our sisters, our mothers, our wives, cousins, sorors, friends. We got to do it. Before we begin, though, I want to just do a little housekeeping. I ask everyone but the current speaker to mute themselves so that we can hear all of the panelists without distractions. Also, all attendees are in listen-only mode, so if you have questions for our panelists as you listen and watch, please post them in the chat for our webinar administrator, Lainey Poi, to gather. We have several question and answer periods built into our agenda this evening, so feel free to post your questions to any of our speakers. Our goal this evening is to arm you with knowledge and ways to advocate for yourselves and for your families in doctors' offices and hospital rooms. So that's all I'm going to say on my part. Now we have to get started to get some of this good information. Let's talk. Our first speaker is Dr. Connie Graves. She is the medical director of Tennessee Maternal Fetal Medicine. Dr. Graves, please share how we can recognize the Black maternal health crisis and then begin transforming our narrative.
Good afternoon, everybody. I believe that Lainey is going to show my slides, only because I have some graphs that I think are really important. Now, just last week, I was able to speak at the Levi Watkins Symposium at Tennessee State University on maternal mortality. And so as we start this conversation, as Lainey is putting up my slides, I want us to think about the things about Black maternal mortality. And one of the things that we need to remember that this just didn't start. It didn't start yesterday. And so it was probably over about 400 years ago when we came over to this country, the inequities that were started at that time. Keep in mind that many of us came from societies in which birth was sacred and women supported each other. And so we left that and came to this country. There is probably no surprise that we are rendered silent and often unheard. And I'm going to talk a little bit about our reimbursement rates for how we care for women, because that's a big area. And then, of course, present some solutions. Now, in 2021, the United States had a sharp increase in maternal mortality. You can see here from 2020, the rate rose for almost 300 more women. Keep in mind that maternal mortality is per
that's a lot of responsibility.
Excuse me? You can go next slide. But when you look at maternal mortality, Black women were more than double the average maternal mortality rate. So overall, you can see that the maternal mortality rate's about almost 30 per 100,000. But for Black women, that rate was almost more than doubles, about 2.6 times at 70 per 100,000. Now, there are many reasons that people think that the maternal mortality went up in 2021. One of the big reasons for the increase in maternal mortality had to do with the rise in COVID. And we know that especially the Delta variant for many of our patients was very detrimental. As someone who practices in the critical care space, I got a number of calls about caring for pregnant women who had respiratory disease. And you know that while often often we talk about normal pregnancy and what we need to in order to care for normal pregnant patients, we also know that the ability to care for critically ill pregnant women is hampered in this country due to the lack of training. Next slide. Now, if you look at maternal mortality by race, this is from the CDC, and you can see that for each subsequent year, maternal mortality has risen, not just for Black women, but for all women. And like I said, in 2021, the rate was 32.9 per 100,000. For Black women, 69.9 per 100,000, as compared to non-Hispanic white and Hispanic women. Next slide. I do think that one of the things that we need to realize is this maternal mortality rate, and this increase is the highest it has been since 1965. So we've made a lot of advances in maternal care. When we talk about maternal deaths, I always go back to the point that my grandmother, who was born in 1900, and the life expectancy for women in this country was at the age of 40. So from the 1900, we have made significant improvements in outcomes. Some of this has to do with improvement in treating infection, the ability to manage hemorrhage. But what we do know is that the rise in maternal mortality is also associated with the failure to diagnose and manage hypertension well and cardiovascular disease, which are intimately related, actually. And when you look at maternal mortality for women over the age of 40, which is another group, you can see that that rate is 138.5 per 100,000. Now, if you put maternal mortality with age and you join it with race, and you look at Black women over the age of 40, you need to understand that that's 300 per 100,000, which means that if a Black woman delivered in the Congo, which has a rate of 282 per 100,000, or Uganda, which has a rate of 284 per 100,000, then the outcome may be equal or the same. And this is in the United States. And so we really need to talk about this, how we can improve outcomes. Next slide. This is from 2014. And one of the things I really like about this map is from the Preeclampsia Foundation. You can see that maternal deaths are concentrated in certain places. The Southeast, they're concentrated and is particularly some of our what we call states, red states, in which there may be lower reimbursement, but due to lower reimbursement, maternity healthcare deserts. But one of the things that we need to also remember is things that protect women against mortality, such as insurance, higher socioeconomic status, and education do not seem to be that for Black women. And we know that Black women with a college education are 5 times more likely to die than white women. Next slide. So before we kind of discuss some solutions that I hope that we touch on tonight, I really want to talk about some of the patients that we need, some patient focused, to kind of get an idea of where we are when it comes to maternal mortality. So here are 3 examples that I want to bring to your attention. Serena Williams was an international tennis star who had to continue to request for care. She complained of shortness of breath and chest pain. She'd had a pulmonary embolism before. They told her that she was on too much pain medications. It was only after she was persistent that she got the CT scan that she requested and the care that she needed. But it could have been different. So here is Shanice Wallace, who was a pediatric chief resident at the University of Indiana. She died 2 days due to complications of preeclampsia and HELLP syndrome. This was a doctor, and the death was deemed preventable. And most recently, Tori Bowie, who died at home from preeclampsia. When they found her, they saw that she had eclampsia. And at that time, it was also noted that she was delivering her baby. One of the issues with Tori Bowie is that she had a deep mistrust of the system. And that is something that we're going to have to address. And then last but not least, Kiara Johnson, who died at Cedars-Sinai from hemorrhage. Her family has actually filed a civil suit because of the fact that they did not pay attention to many of her complaints. And at one point, it was said that a nurse told her husband that she was not a priority. So if we're going to talk about maternal mortality in face of and talk about especially hypertension and maternal mortality and cardiovascular disease, there are some things that we really need to be willing to discuss. And as we go forward tonight, I hope we discuss the structural and institutional racism, which has led to the issues that face many people of color. I tell people, I am a child of the early 60s. I was born in a clinic. My mother and father both had master's degrees. My mother was advanced maternal age, but there was no hospital that would admit Black women. Many of those structural and institutional barriers are still in place today. And while they may admit Black women or other people of color, what really happens is we're admitted, but we're not treated the same. So we must focus on health equity and bias in the healthcare system, how patients can access the system, and how they can be advocates for themselves. There's great data out that suggest that the effects of long-term stress of being Black or a person of color in America can affect pregnancy outcomes. Geronimus in her study showed that Black women are about 5 to 10 years older than their non-Hispanic white counterparts. More importantly, she showed that the optimal age for birth for Black women was toward the end of their late teens and very early 20s, where the optimal outcome for white women was in their mid to late 20s. So we have to talk about when birth may be optimal in order to prevent some of our outcomes. Next slide. One of the things I believe is that we have to see the birthing years as part of the healthcare continuum. And one of the things I really love about the Preeclampsia Society is that Preeclampsia Society is not just focusing on pregnancy, but focusing on women who've had an adverse pregnancy outcome in the terms of high blood pressure. What we do know is that women with high blood pressure are more likely to have a poor, like I said, adverse pregnancy outcomes, but not just adverse pregnancy outcomes, but adverse lifetime outcomes. In fact, women who have preeclampsia before a gestational age of 34 weeks, within 10 years, are more likely to die of a cardiovascular event, including heart attack, stroke, or other issues associated with high blood pressure. So we must be able to see that when we have these adverse outcomes, that patients are getting follow-up, and not only are they getting follow-up, but they're entering into studies so we can better understand which patients are going to go on to have issues that possibly and hopefully we can prevent in their later life. We must be advocates, all of us, for our patients. We must be advocates for ourselves. And though I saw something says that we have to have more midwives, we all have to learn to work together because we all have a role in taking care of patients. I take care of very sick patients in the ICU. I have, the understanding of cardiac physiology and the physiology of high blood pressure is really important. But we also need to make sure that women have appropriate access to care. And last but not least, and this is one of the things that we're doing tonight, is we must think outside the box and address the complex issues that address the increasingly complex increased medically complex population is what I want to say, not complex medical population. But our population is complex. We have a higher rates of obesity. We have higher rates of high blood pressure that present in pregnancy, higher rates of diabetes that present in pregnancy. And what we do know is often these women do not get the counseling that they need prior to pregnancy in order to prevent some of the complications that we're seeing in pregnancy. And this is not going to change. I feel as our population increases, again, as many of our women are delaying childbirth to later in life, we're going to see more complications. And as I showed, at higher rate of maternal morbidity and unfortunately maternal mortality, unless we get the word out that these are some of the issues that we are seeing in our data. I thank you for your attention. I want to stay on time, and I'm open to questions at this time.
Thank you so much, Dr. Graves. That was not only informative, but I believe that was a call to action. I believe that was it. There's so much that we need to do in the community. There's so much that we can do, but I do agree with you when you said that it's going to take all of us together to get things done, right? I read somewhere that when a Black woman dies, it causes a ripple effect. When she dies in childbirth, it causes a ripple effect, not just among her family, but also among the community. So definitely we all, you gave us some really good information to not only think about, but just to really find, solutions. So thank you for that. I'll open it up to questions now if we have any. Lainey, do we have any?
We don't have any questions this time, so let's move on to our next speaker, Ms. Rolanda.
Yeah, excellent. Dr. Graves, please hang around because I know that eventually somebody's going to may have questions for you. So please stay on the Zoom and we'll continue.
There is one question that says, do we know why high blood pressure and preeclampsia are so high in communities?
Oh, good. Okay.
So, and sorry, my very efficient employees have cut out my lights because they know they've left, so I have to go back and put my lights back on.
Okay.
But I'm a little bit in the dark right now. But one of the reasons is that we do know that some of it's genetic. We know that I often point out that Black women have been selected to have high blood pressure. And it is not, when we came over from the Middle Passage, you have to think about how we came. The people who were able to survive have two things. They were able to store their sodium. They were able to keep their volume, intravascular volume. Otherwise, you'd have died of shock. And they were able to store minimal food as much as possible. So when you think about that and the population that made it across the Atlantic Ocean, some of our things are very much genetically selected for. And then when you put them into spaces with poor diet, areas where exercise cannot be done, we then have the combination of having high blood pressure and diabetes at higher rates than other populations, not because we are, as you said, is not because we are neglectful or ignorant, but because we are already genetically predisposed to have some of these conditions. And often this is not something that people talk about. We don't like to talk about some genetic predispositions, but it is a fact that, I actually had the privilege of going to Africa and seeing the middle and seeing Ghana and Elmina, where people were put onto a boat. It's a long way across. And so people who survived had special factors that go into why we have slightly higher rates of high blood pressure and diabetes in this country. Like I said, along with our diet, that the American diet is probably going to be the downfall of all of us, actually, because it's very high in carbohydrates and very low in nutritional value many times.
Okay. All right. Okay, well, next up, thank you so much again, Dr. Graves, for answering that question. And I see that the person says thank you for answering it as well, who posed the question, so thank you. All right, next up, we have with us Porsche Holland Otunba. She is a proud Philadelphia native, she wanted me to say that, wife, girl mom, and HBCU alumna from Tuskegee University. She is also a third-generation preeclampsia survivor and has experienced birth trauma. She also, from that experience, she was able to start and is the CEO of Reclaim Black Motherhood, LLC, which is an organization that's dedicated to birth workers and contributing to everything from program management to research efforts when it comes to birth, postpartum, mental health, and lactation spaces. Porsche, please discuss with us the role of our voices when it comes to quality improvement work in Black maternal health.
Good day, everyone. Just to premise, please don't be surprised if you hear little voices all around. I try to hide myself as best as possible while in the midst of travel, but there may be some of our little blessings running around, as they say. So I am a survivor of birth trauma, a third-generation survivor of preeclampsia, a survivor of difficult and challenging, listen, difficult and challenging birth and lactation experiences. And it's because of that and my two little blessings that I do this work. And so for me, I wanted to point out the Philly piece. We are a city of advocates. We play no games, particularly in the Black justice streets. And so for me, being born in 1986, at a birth center, which is no longer standing, and my mother had preeclampsia. I was 4'11" when born, but she was treated and cared for so beautifully by midwives under the direction and support of OBs that were there in the case that something was needed. Though she was on bed rest, and though she tried to do whatever could be done at the time, right? It was still toxemia at that point, that I was able to grow and be healthy and strong. My grandmother, who is still with us today, 85 years old, she survived toxemia, but my uncle did not. And so she had to unfortunately carry a sleeping baby. And given what we have now in terms of some lack of resources, lack still of understanding, lack of funding and support around research, just imagine how difficult it was at that time, with limited answers, limited support, just limited everything at that particular point in time for her life. And so I say that to premise why, for me, with my first child, since it was the first for all of them, I thought I had escaped it. My baby came in 2017, y'all. I thought, ooh, preeclampsia, it done went past me, y'all. I'm good. Second baby, out of nowhere, right? I had started having some elevated pressures just before pregnancy. Well, my grandma was dealing with cancer again, right? That beast of a thing. I was getting married. That's a little stressful, you know? So I'm thinking to myself, oh, maybe it's a little white coat. Maybe I'm just ordering too much Uber Eats. The Rona got us crazy. So my PCP's watching and keeping an eye. But just before getting pregnant, our little honeymoon blessing surprise, I started medication to actually address the elevated blood pressures, as there were some trends. And so I tried so many remedies and things. I really took a holistic, natural approach during my pregnancy, and consulted herbs and different things. And it wasn't until maybe about 35, 36 weeks, we started seeing some concerns. And I was under the care of a midwife pursuing a VBAC. And so for me, y'all, it popped up at the bitter end, but it was there. And that's when I began to say, why didn't I know this? It shows up for anyone at any time. Sometimes you can predict it, sometimes you can't. Thank God I didn't have any severe issues or concerns. I am chronic hypertensive, and so I do take medication at this point, but the horror stories that I had heard for some people wasn't my story, but I had one in my maternal line. And as I began to sit with my grandmother, which I do plan to capture our stories, but I want to really be intentional to capture this before she leaves this place. we couldn't trace back too far in our generational line because some people didn't have the language or the consistent care, or there wasn't just knowledge, right? But something was going on and it could have impacted my maternal line for generations. So y'all, this is sickening to me as a survivor, as one that has lost a family member, as one that has looked this thing in the eye and is doing what I can do now to address cardiovascular disease in my own line and in my own body. I have to say something. And so being a proud advocate, if you look at my social media, you see what I talk about, you're going to see preeclampsia in the midst. To be a Take 10 for Preeclampsia Research Initiative partner is a privilege, honor, joy, and blessing to be able to say, you all, there are some things that are lacking. And researchers will tell you, it's not the hot, sexy topic. So people aren't throwing money, time, and effort at it. Well, guess what? When I get on the mic and start telling you all about the stories and start raising the roof and screaming and hollering and crying, somebody gonna listen on today. Okay, we need to shift some funds and shift some focus. And while Black maternal health is hot in these streets, right? Because it wasn't, right? The Black bodies have never been valued. I was talking to some folks about that last night in a meeting around funding for Black-led CBOs in maternal health. Why should we be shocked that funding is short when our bodies have never been valued? And so though it's hitting the airways and the media and the streets and elected officials now want to shake a little bit, all of that is cute. It's very cute. What do we need to do with preeclampsia in addition? We're fighting for lactation, we're fighting for birth, we're just fighting all around. And so for me, I count it a privilege to say, I am a survivor. I'm standing here, and with every breath, I'm going to ensure that people understand that there are myths, there are rumors. And so a lot of my content also addresses some of that. Where is the evidence? Where is the funding? Where is the support for research? Because in the year of our Lord 2023, throwing aspirin and we don't know what else, and we can't tell you, and this is that, and maybe, and it went undiagnosed for some or didn't get caught for others, or people still having eclamptic seizures and don't know and nothing's happening, or people are too afraid to go get care, so therefore they can't see the trends, we have an issue. So can we teach people how to monitor? Can we make sure everyone has a blood pressure cuff? I do that as well, making sure families that I engage with, I've gotten coins from people to help do some of that work. I know the Preeclampsia Foundation supports that as well. Not to wait until you get to an appointment. If you feel like going or taking off from work, monitor at home, boo, record the trends, right? I found that to be beneficial in my own life in the midst of COVID when appointments were a little bit rocky. And so we can't wait on this thing. It needs to be common knowledge. It needs to be taught, integrated into K-12, like some of this other foolishness they're teaching. We need to really center reproductive and perinatal health. And so that is my rant. I am here to support, to rally, to be alongside. And so not only do I share the passion as a survivor and a mother, but also a birth worker, a Black maternal health advocate that is not playing games with folks in these streets. So however I can be a support to anyone's initiative or work around research specifically as a research nerd and head, but also just spreading the word and hitting the streets, the corners, the pavements, the blocks to let everybody know, if you see a bump, this is something we should be talking about, not to scare you, but to just make sure you're aware and have magnets and things in your house. So if you start seeing trends, you know to run to the ER. And if they don't listen to you, run to another one, because we got that as an issue too. Some of them ain't listen to us. Okay, now that is what I am here for. And so thank you so much. And for everyone that is a supporter and locking arms with me nationwide to ensure that our folks know about the power of education and support around preeclampsia.
Thank you so much, Portia. I always love your energy. I love the passion that you have with this topic. It comes through, and you back up your words. You know, I've seen you do actual workshops on this. You just recently had one, I believe, a month or two ago, right? Yeah. So thank you so much for that passion. I do have a question for you, though. what would you say to an individual who doesn't feel like their voice matters? Like what would be the first step that you would tell them to take to, find their voice? Because we're talking about amplifying your voice, but some people, when it comes to dealing, especially with medical professionals, they don't feel like they have enough confidence or enough knowledge to even really articulate what they're feeling or what they're going through. So what would you say would be the first step to that? What would you tell them?
Absolutely. I would say to recognize that someone is an expert, but that there is still space and room for your opinion. So yes, I go to the mechanic because I don't know about the pieces. But if I already Googled something and looked over something and I'm not feeling like they're charging me well, I still have a right to say something. So I respect the person practicing medicine, the person that says they're an engineer, the person that says they're a plumber and coming past my house to fix a thing. But I still have a right to ask a question. And I would also encourage them to practice advocacy. And I would recommend the Black Coalition for Safe Motherhood ACT training and workshops so that they can actually do that in a space with people that look like them, so that when they interface with the medical industrial complex, they are prepared to do so.
Excellent, excellent. Thank you so much. We appreciate your voice. And just knowing that, there are women out there who will even serve as, your guides, models, role models, what have you, to help other women find their way. So thank you for that. Next up, we will be discussing nurses and midwives' role in patient care and advocacy to keep women safe. And we have with us two nurses, as well as one of them is also a nurse midwife, and we will start with her, Dr. Alexis Dunn Amore. She is a clinical associate professor at NYU's Rory Myers College of Nursing. She is committed to advancing the health of the most vulnerable. Her clinical practice, teaching, research, and service are focused on dismantling perinatal health disparities, addressing racism and bias in midwifery, as well as nursing education, and developing initiatives to address the root causes of maternal mortality. So Dr. Alexis Dunn Amore will speak now, and then right after her, we will have Carthenia Jefferson, who is not only a legal nurse consultant and a nurse, but also she is an attorney, a medical chart reviewer, a speaker, and a thought provider when it comes to talking about topics like nursing and the law, end of life issues, breast cancer awareness, domestic violence, the Affordable Care Act. She is also chair of the National Black Nurses Association's Ad Hoc Committee on Violence Reduction. So first we will hear Dr. Amore and then followed by Carthenia Jefferson. So thank you, ladies, for being on this panel.
Thank you so much for the introduction. It's an honor to be here. I'm Dr. Amore. I am a professor at NYU, but I am Southern born and raised. I actually reside in Memphis, Tennessee, and I'm the director of midwifery at a birth center here called Choices. And so I want to share with you a little bit about my journey in midwifery. The talk really just kind of helps you understand what is a midwife, what is our role, and kind of, some of the things I've been able to accomplish as a nurse midwife. I also am the vice president of American College of Nurse Midwives, which is our national organization representing midwifery for the United States. So next slide. So you may be asking yourself, what is a midwife? We throw this term around a lot, but we practice in a variety of different settings. We have a lot of different certifications and scopes of practice. And what you're seeing is a rebirth of traditional midwifery in the workforce. So I'm a certified nurse midwife. This means that I was trained in both nursing and midwifery. I have a graduate degree, so most of us are either master's or doctorally prepared. So I have a PhD. We can practice in the hospital, the home, or the birth center, and we are licensed in all 50 states. We also have certified midwives, which are individuals who are not necessarily nurses, but who may have degrees in other fields. They go back and they pursue a graduate degree as well, and they're able to also obtain a midwifery degree. They can practice in the hospital, birth center, and home. But right now, they're only licensed in about 9 states in the District of Columbia, but that is growing. You also have a certified professional midwives. And so these are midwives who train by apprenticeship, which is the more traditional model. They have accredited programs. And with those, you have to have a high school diploma or equivalent, and it is competency-based education. And once you complete that training, you're able to practice in the birth center or home. They're currently licensed in 35 states, as well as the District of Columbia. And then you have our traditional birth attendants and traditional midwives who train by apprenticeship and self-study and primarily practice with home birth. And so there are many different types of midwives. There's a lot of debate about who should be able to practice where. I personally believe that there's room for everyone, as has been mentioned on this call. Everybody has a role. But sadly, in the United States, there are a lot of barriers to practice for midwives by state laws. Some things upheld by medical institutions that do not understand midwifery and nursing. But I do think that there are many who do understand and that we are on our way. I think together we will be able to make a difference. Next slide. So as far as, what we're able to do as midwives, we are trained across the spectrum. So as a nurse midwife, I don't just focus on birth. I can provide preconception care, which is care before, during, and after pregnancy, care of the newborn up to 28 days of life, but also primary care, GYN, and family planning services, as well as treatment of male partners for STDs. So it is a reproductive spectrum that I am able to practice along. Certified professional midwives tend to focus more on the labor, birth, and immediate postpartum period, as well as maternal and well baby care through the 6 to 8 week postpartum period. And traditional midwives focus on prenatal care and delivery, as well as postpartum and newborn care. Next slide. So what is the impact of midwives? Well, you have to remember, before we had our modern setup, most people in the United States, as well as in other countries, were cared for by midwives. In this country, there were primarily immigrant and Black midwives. And so that was who you went to for births. You could see it in the movies. You could see it, if you just do a quick Google search. Midwifery was the standard of care and is the standard of care internationally. But around the 40s or 50s, you see the emergence of obstetrics. You see the emergence of nursing. And then there was this systematic campaign to eradicate and eliminate the traditional immigrant as well as the Black midwife. And so there were campaigns to call us dirty, uneducated, untrained, and some of that still persists today. And so we have a maternal health crisis. Midwifery and nursing is a profession that was naturally embedded in the community. There was trust there. You existed among the community. As a matter of fact, midwives took care of the whole family. It wasn't just pregnant women, right? We know that midwifery care is associated with decreased interventions, decreased number of cesareans. You have higher numbers of unmedicated vaginal births and better outcomes. But also when you talk with birth and families, the better experiences. Having a vaginal birth with no lacerations is all good, but a lot of those people still have birth trauma, right? It's about the experience. It's about who you became during that birth process. It's a transformative process. So as midwives, we are dedicated to not only your health outcomes, but your experience and making sure that you're taken care of during that time. I wanted to share with you all an app. Miss Irving is here, Wanda Irving here, representing Dr. Shalon. And I just want to acknowledge that I am grateful to be here today to speak on behalf of people who were unfortunately not able to be with us today because of these health outcomes. And so she was very helpful to me when I was developing this web-based platform. It's called Mama Love. You can scan the QR code, or you can go to the URL mamalove.love. So that's MAMALOVE.love. And it's a platform that I developed research. I'm a researcher. And so I did focus groups with MFMs, OBs, nurses, nurse midwives, as well as women who had severe maternal morbidity or who had near-death experiences, and talked to them about what are the things that you wish you had to help you when you had symptoms. So when you go into this platform, it has a physical health section where you can look at different physical symptoms. It has a mental health section, and it also has a social screener. And so you can go through, we build out the algorithms, and it'll kind of tell you, hey, you have a symptom based on what you selected. You might need to call 911 or seek emergency care. Or it may tell you, hey, you need to call your doctor or provider for some urgent follow-up. If you don't hear from them within that hour, you should proceed to the hospital for care. Or it may say, just schedule you on a doctor's appointment. This is not as urgent. but all of it will give you some resources that you can read up on to kind of help you to make those decisions. And so please share this broadly. It's free. There's no, when I developed this, I never wanted to make money off of it. I just wanted it to be out there for people to be able to freely use. Next slide. So I want to tell you about my clinical practice site. So I am a director of midwifery at a clinic in Memphis called Choices. Choices is a full-scale reproductive health clinic. We are there to serve our community. We believe that you should have the right to birth when and where and how you want, or if you don't want to birth, same thing. We also provide gender affirming care. We provide wellness care. And so this is the team here of 6 Black nurse midwives who provide care to the city of Memphis. We practice holistic birth. We believe that you should feel safe in your pregnancy. And so we have created this haven here in Memphis to try to care for Black and brown people, but anybody that desires to have out of the hospital experience. The problem is people put those same pressures on us that y'all are unsafe. You're doing something that is hurting the community. And that's not the case. I practiced in Georgia before I came here. I was hospital-based. I worked alongside MFMs and OBs. Most of us have, and so we are not unsafe. But unfortunately, we have challenges with that perception. We have challenges getting our patients transferred to the hospital because people don't want to receive report from us. They have this, when we talk about systemic barriers, even though we have shown, and I'm going to show you in the next few slides, that we provide stellar care, that systemic issue is just there. So even though our patients are very happy, we still can't get the care that we need. Next slide. Yes, Talita. I see someone says Talita. Yeah, that's a big crew. I'll introduce them. I know some of you may know them, but we really are, we're sisters. We work well together. So this is data 2018 to 2023, actually. So we've been doing births at Choices for about 5 years. Right now, I'm a researcher, but we're partnered with UCSF in California to do some analyses where we're looking at our birth outcomes compared to Tennessee and national data. So right now for births at our clinic, our overall preterm birth rate is 2.1% as compared to Tennessee, which sits at about 10.9, and nationally 10.1. When you look at preterm birth rate for our Black mothers, it's even more pronounced. So our preterm birth rate right now at the clinic is 2.5% as compared to 14.6 in Tennessee and 14.2 on a national level. And when you look at our C-section rate, 7.9% as compared to 32.1 and 31.8. And when you're thinking about maternal mortality, a lot of it is related to preeclampsia, hemorrhage, and different things. And we know that C-sections often can set you on that trajectory for having hemorrhage, for having infection, for having a lot of those poor health outcomes that can contribute to mortality. So by stopping this before you ever even get there, by preventing that first C-section, by ensuring normal, natural, physiologic birth, we are conferring, decreasing the risk for maternal mortality. Right now, we've had no maternal mortalities in the building. We've had no neonatal mortalities, and we're very proud of that. Next slide. So what this means when you look at that, and just to put it in English, that means that a birthing parent at Choices, regardless of your race, is 5.8 times less likely to have a preterm birth. If you're a Black person, that's 6.6 times less likely to have preterm birth, and also 5.5 times less likely to have a cesarean. Next slide. So I could go on and on and on, but this slide shows you we have health disparities in many different areas. Gestational diabetes, we have it in preeclampsia. These two pictures, I always like to share this. The one on the left is when I had my first daughter, Aubrey. And I was a severe maternal morbidity, near-death experience. And it's what set me on my trajectory to become a researcher. I wanted to understand, how do I systematically collect data? How do I use that to inform policy? How do I use that to inform interventions to help women like myself who were, whether you're educated or not, you shouldn't be scared to have a baby. It shouldn't be that I'm just, something that's supposed to be a joyful, happy time has this cloud over it. And I just think that that's unacceptable. And that's why at Choices, we practice the way we do. I teach my midwifery students, trying to train them up in a reproductive justice model so that they understand what some of those barriers are and how to overcome them. And then the picture on the right is my best friend's baby. 6 months after I had my daughter, Aubrey, when I had the severe preeclampsia, she had a very early preterm birth and had a baby at 23 weeks and 6 days. And again, we both were just dumbfounded as to why how did this happen, right? And so both her and myself have been fierce advocates. We feel like we can stand on data, we can stand on our experiences, but most importantly, midwifery needs to be amplified in this country. We need to be able to practice to the full scope that we're trained in. We need to be able to provide full-scale reproductive health, getting people healthier before they even ever get pregnant. And so I think that is the way forward. These are the things I'm working on. And I thank you for this time to speak to you about this today.
Excellent. Thank you so much. Thank you so much. Dr. Dunn, I have a question for you. Dr. Amore, I'm sorry. When it comes to midwifery, I'm sorry, I'm trying to say that word. Have you seen hospitals start to try to get midwives as part of the staff? Is that a movement that you're seeing happening, or have you seen it happen?
Yes, there are midwives, depending on the state, that are heavily embedded into the healthcare system. So like, for instance, in New York State, where I am, they're in a lot of the hospitals there. I know in Georgia, it's embedded into the hospitals really well. Mostly, you work with like a private. So like if Dr. Graves had a practice and she hired midwives, you'd be affiliated with your private practice, and then you would get privileges to deliver the babies at the hospitals, right? There are some hospitals that employ hospitalist providers. So they're just on staff there to provide the care. So it kind of depends on the state and kind of the model. Here in Tennessee, where I am in Memphis, the regional one is kind of the main hospital in the area. They do have midwives that are in hospital. And then we at the birth center are the only midwives outside of that. I don't think it's not as well, the midwives are not well integrated here in Memphis. I know in the Nashville area, Dr. Graves, I think you're around the Nashville area. They're at Vanderbilt and a little bit better integrated, but we still have a ways to go.
At where I practice, it's Ascension St. Thomas, which is the leading deliverer of babies in the state. We have midwives, and they're integrated into our system. In fact, they don't even, we kind of have an open model where they can even just talk to the maternal fetal medicine specialist, and get advice, as well as the hospitalist or another supervising OBGYN. So they're quite integrated into the system to provide care.
Do you know of any studies or any information as to whether the hospitals that have integrated them into the care, what are the mortality rates like with that?
I haven't seen data looking at hospitals specifically and their outcomes. I know more about data looking at midwifery care and its outcomes. And there's plenty of data that shows that midwifery care is associated with lower rates of all the things I talked to you about, the complications, the mortality, things like that. I just think the challenge is midwifery is not well understood. People believe that, people are not trained professionals and don't quite understand it. So I think that there is definitely room for growth and development around that. And I think it's not even so much, having us as midwives is one thing, but it's our model of care. It's the way we provide care. So until we can ramp up our workforce, because we're a relatively small workforce, there are about 15,000 CNMs in the country, and of those, only 900 are Black, right? So we have a disparity even within our profession, right? So to ramp up our numbers, it's going to take forever, right? And we have a crisis. So I believe the solution would be more to partner with academic medical centers and models, whether that's with physicians and residents, nurses, to train them in that model of care, having midwifery-led clinics inside of hospitals or midwifery-led units. So using that model of care to propose a different way of impacting the larger system.
Yes. Okay. Yeah, I totally agree with you. And I'm hoping that that's something we can push for, So
yes, I agree.
Thank you
so much.
Well, now we will have Attorney Carthenia Jefferson. Thank you so much, Ms. Jefferson, for being here. And thank you. You also have had a couple of month of nonviolent events yourself. So thank you so much for doing that. And now we'll let you give us the violence reduction part of this.
Well, first I want to thank the group for inviting me to speak on behalf of the nurses as a nurse and an attorney on examining Black maternal health. through the lens of advocacy and nonviolence. As
Mhm.
you stated, I am a nurse and an attorney, and we have been having several events around the country with Black Women for Positive Change. But what I want to, in my brief amount of time, speak to you about is about pregnancy, violence, and the nurses' roles.
Mhm.
We know during pregnancy, there's a increased stress, there's increased worry, there's pressure, there's frustration, there's confusion. And sometimes when you have this coupled with racial disparity, healthcare disparity because of your person of color, that just increases the amount of stress on you and the stress on the fetus. So I just want to say, first, difficult, complicated reactions to pregnancy. As I stated, the stress, the worry, the depression, the frustration, and these can lead to stronger emotions that will cause increase in violence. When anger becomes violence while the partner is pregnant, there's verbal abuse, emotional abuse, because we can't control anybody but ourselves. And then that's the physical abuse. The physical we can see. The emotional, mental, we can't see. And it affects the mother, the fetus, and the family as a whole. And pregnancy, as was stated by what the previous speaker, should be a happy time. It should be a happy time. But when a woman goes through all of this, as far as the stress, the frustration, the physical, the verbal abuse, and person saying things they normally may have not said if the person was not pregnant or because of an unplanned pregnancy. You know, mortality increases with unplanned pregnancy. Domestic violence increases with unplanned pregnancy. And this has a horrific effect on the mother and the fetus. Reading through the CDC concerning pregnancy and violence, it says violence during pregnancy can cause miscarriage, a high chance of premature birth, and newborn death. Violence can cause a pregnant partner's stress hormones to rise. These stress hormones go through the placenta to the growing baby, and they can have a negative effect on the baby's development. And violence can cause a pregnant partner to feel very anxious, as I stated initially. Anxiety can have negative effects on the baby too. And I think that's sometimes what we forget. So the mental health aspect, the nurses, when you have a mother come in, we always try to do an assessment in the emergency room. There are several questions that are being asked, especially if violence, it appears that violence took place. And normally we ask if a partner comes in, if we have a woman come in, say with some injuries, we do that assessment. And then we've asked if there was any falls, anything in the home that happened, or you feel like you're in a safe environment. That question is asked very frequently. And if you have a partner in there with the woman, of course, she's going to say no because she feels threatened, or she feels like she may be abused later when she goes home if she says something. So as a nurse and an attorney, I see this quite frequently because I do a lot of domestic violence cases. And we have mothers that come in and they have been abused, but they fail to say something. They fail to say something on being accessed at the emergency room. They fail to say something even if somebody has reported it. And a lot of times they won't come to court. So what are the things that can be done when you see this violence reaction? You see something, you say something. You see something, you say something. you need to get some help, because the effects of violence during pregnancy, violence can cause a pregnant partner's stress hormones, as I state, to rise. Violence can cause stress to the woman, and also to the infant. And some of the questions that I looked at that may be asked concerning violence during pregnancy: the effects of domestic violence during pregnancy, injury to the uterus, miscarriages, I stated, stillbirth or premature baby, getting a dangerous vaginal infection, because sometimes people just look at physical violence, as I stated. There's emotional violence, and then there's sexual violence. So getting an infection during your pregnancy because of forced or unprotected sex with someone who has an infection increased, and this is increased in the first and second trimester. How much domestic violence is related to pregnancy? It's stated that nearly 20% of women experience violence during pregnancy, with pregnant adolescents and women with unintended pregnancies, as I stated before, at an increased risk. Nearly 20% of the women experiencing violence during pregnancy, that is a high number, 20% during pregnancy. Is pregnancy a risk factor for violence? As I stated, with unintended pregnancy, because of the frustrations, sometimes with both partners, the violence and the risk factor increases. Can abuse affect pregnancy? Yes, abuse can affect pregnancy. And they say the high mortality rate of 30%. It causes poor prognosis for both mother and fetus, regardless of the state of pregnancy, but more so during the first trimester. And looking at the abuse, it stated that 34% of abuse with that trauma mortality, 57% related to homicide, 9% to suicide, 34% to injury and accidents. And what are the three high-risk pregnancies? As I think Dr. Amore was stating about high blood pressure, diabetes, being HIV positive, overweight, and obesity. But what is the most vulnerable stage? We have a lot of women, because I do family court. Not only is it violence, but it's these drugs, drug abuse, alcohol abuse, smoking, all of that can affect the child. And if you, well, the fetus, and if you have a partner that is in the home that is doing this, or the mother herself that is doing this, that can have adverse effects on the fetus. I looked at what abuse is more common in pregnancy. They said some partners become abusive, as I stated, because they feel upset because of the unplanned pregnancy. That was the most abuse, where abuse was more prevalent. Can emotional stress affect the pregnancy? As we stated, yes, it can. Mental, emotional state of mind can affect the pregnancy. And we try to tell the women, especially those who have been in a domestic violence situation, if you are having problems in the home, seek help. Seek help. Don't be afraid to seek physical help, as far as going to the emergency room, being assessed. And when the nurse asks you during the assessment, do you feel safe in the home? Like I said, most of the times we have the person, the partner, not to be in that same room, especially if violence is suspected. But as I stated, the first trimester is the most crucial to the baby's development. During this period, your baby's body structure and organs, systems are developing. So most miscarriages and birth defects occur in this period. And if a woman is in a violent situation, say a lot of, I'm not going to say men, but a lot of partners will hit the woman in the stomach. And a lot of states have laws that if you abuse the the mother, or you're abusing the fetus of a pregnant woman, that is not just one charge, but there are two charges, especially if death is involved. So what I tell people, if you see something, say something. Don't be afraid. Tell your nurse what's going on. And as Dr. Amore was saying, we need more trained individuals to assist in helping these midwives to get the training that they need, because without the proper training, if you go to a medical facility or urgent care facility, sometimes that is missed. And a woman will go back home to that same environment because we missed the cues. I have clients all the time that are in this environment because they feel like they have to be in it. Maybe because of financial reasons, maybe because this is all they know. They don't work, and they feel like this person, it continues to say, I love you, I won't hurt you again. And we had a domestic violence webinar this week. One of the speakers, Dr. Ruth Lynn, spoke about being abused, the effects it has on not only the mother, the fetus, but also the children as they develop. So it is very important as being an advocate for your patient, to be an advocate for your patient and speak up and say something, and your proper documentation as nurses, and all of us, as Dr. Moore said, we need to be trained on how to view these clues that we have when we're doing our assessment, not just the physical abuse, the emotional, mental abuse. If there is something that needs to be done, maybe the woman needs to be referred to a psychiatrist or for therapy or whatever we need to do to assist these women to get help, because there is racial disparity out there. There's healthcare disparity, as Dr. Moore said. And I think one of the other speakers was saying sometimes women are just sent home over and over again, especially Black women, when I say about healthcare disparity. I have a client now. She went to the hospital 5 times pregnant, had started bleeding, and still was complaining of severe excruciating pain. Sent home 5 times. The baby, the fetus, expired. The fetus was around about 8 months, expired. She took a picture and brought it to me of the fetus. I mean, a sad situation. She lost a lot of blood. She had to have treatment for over 3 months, blood transfusions and all of the sort, treatment for 3 months. Because guess what? When women are not insured or don't have enough insurance, I say underinsured, sometimes they sit back home over and over and over again. And I know some of the persons on this webinar have seen this happen, especially the midwives that just spoke, Dr. Moore. You've seen this happen. But we have to encourage our Black mothers to seek help, to continue to go back. I don't care if you turn away. This mother continued to seek help. And she didn't die. But I did have a male that came to me, his wife and the baby died. So we just have to encourage our mothers to please speak up. Please speak up, regardless of the situation, whether it's you feel like it's racial discrimination, healthcare discrimination, violence, please speak up. If you see something, say something. And I thank you all for allowing me this time for the presentation.
Thank you, Ms. Jefferson. Thank you so much for that. So if you see something, say something. Wow, that's powerful. We did have a question from Jacqueline Stiff. She said, for women who are fearful of reporting, but as a nurse, you clearly think there is violence in the home, how do you convince them to seek help?
Well, it's hard to convince them to seek help, but you talk to them, you be patient with them, and don't be judgmental. Please don't be judgmental, because these women are already under stress. So it's affecting them and it affects the fetus. Just listen. The main thing to do is listen. Try to encourage them to get help or to make a plan. So sometimes it takes, as I think one of our speakers said, Dr. Glenn, during her presentation, it may take up to 8 months for the person to leave. But if they feel like you are not judgmental and are listening to them, they will usually listen to you and they will think about that situation. But we have a duty as nurses, a duty to report. Remember that, nurses, you have a duty to report. I don't care if it's your friend or whoever. If the person comes in through the emergency room, if you think it's abuse, write it down. Because let me tell you what happened with one of my clients. Went to the emergency room, had black eye, had bruises, and she just said she fell. I know a lot of y'all have heard this and seen this over and over again. But if you suspect violence, you have a duty to report.
Wow, thank you so much. Ms. Stiff, did you have a follow-up question? I saw that you were on the screen a second ago. So I just wanted to open that up to you if you wanted to have a comment or anything.
No, that was great. Thank you very much. Appreciate it.
Thank you. Thank you. Oh man, so much information is being shared. Please continue to put your questions in the chat. If you have any questions regarding what's going on tonight, ask the question. Don't be shy about it. You may be asking for others who, can't ask at the moment. So please do. We're going to continue on. Next up, we will have Dr. Valda Crowder, who is a medical MD, a medical doctor, and she actually is a medical expert who is also on the front line of the gun violence and mental health crises. She's gone through 4 pandemics, natural disasters. She's a board certified emergency medicine physician for over 30 years. Currently the director of emergency medicine at the University of Pittsburgh Medical Center's Community Hospital in Harrisburg, Pennsylvania. So now we're going to hear from Dr. Crowder, and she's going to continue this discussion, talking to us about, just looking at how do we help pregnant patients and their partners navigate the emergency department. How do we do that, Dr. V?
Hi, thanks. Thank you for that introduction. So, there's been a lot of slides here about maternal fetal health. And I think it's important to remember that some people die in those columns of maternal fetal health not knowing they're pregnant, right? So I start with, people who come into the emergency department when I think there was a question in the chat about whether or not they know what preeclampsia is. Some women don't know they're pregnant, right? So I would say, first of all, if you're a woman in America, it is really, really important that you know the laws of your state. What happens if you become pregnant? What happens if you have complications? What are the conditions under which you can terminate that pregnancy for even medical reasons? We now have states where they're required to let you be near death before they can actually intervene and medically terminate your pregnancy. So all of the bar graphs that Dr. Graves showed earlier, which were great, are only going to get higher as a result of what we're seeing in some of these states. So the first thing I say to people is have a plan. If you are a woman in America today, you need to have a plan if you live in one of these states that have very restrictive and regressive laws. Specifically, set aside money for travel. Where would you go? If you had an unplanned pregnancy? Is there a state near you? Is there family members near you? If you have a daughter that is going to college in one of these states, what is your plan for your daughter or your granddaughter or your niece, right? So I think that, there's a lot that occurs even before someone realizes that they actually are pregnant. Now, let's talk about when you actually become pregnant. I know there's been a lot of talk about not having resources in people not having resources in their neighborhood, and not having either birthing centers or not having primary care providers or OBGYN doctors. I want to actually, we've talked a lot about the importance of resources, but I want to really be clear. Those people that have Medicaid or are underinsured for any other reason, the reimbursement rates are lower. And that's why the doctors are not in your neighborhood, right? And it is really, really important that when we talk to legislators and when we vote, we ask for reimbursement equity, right? It is really, really important that that there is the same amount of reimbursement, whether or not I have Medicaid or any other insurance, right? To make sure that we don't have these medical deserts. Now, when you're also pregnant, it's important to know what hospital does your OBGYN practice in. I'll give you a very good example. Just last week at my hospital, we do not deliver babies at my hospital. We have no obstetrics and gynecology. We only have gynonc, which is when people have a gynecologic cancer. There was a woman that was 38 weeks that walked into our emergency department. And, we then have to transfer that patient to another hospital, which is a delay of care, right? So the hospital that does deliver, that is affiliated with us, is probably about 8 to 10 minutes away, right? And so I think it's really important, know where your OBGYN practices. If you do not have an OBGYN, know which hospitals in your areas deliver babies and which ones do not deliver babies. If you're not sure, call 911. 911 will take you to the right hospital almost all the time, right? So 911 will not take a very pregnant woman to someone that actually to a hospital that does not deliver children. The other thing that's important is know what's usual for you. Specifically, what is your normal blood pressure? What is usual for you around your breathing? What is normal for you around your activity, exertion? What is normal for you around your pain or discomfort that you have had with pregnancy? So you can really relate your symptoms as this is normal and this is not normal for me. When was your last menstrual period? How many pregnancies have you had? What happened to them? Know your medications and allergies. These are basic things that I tell women, put them on a card. Sometimes in the heat of things and things are really going, you could even be someone who's not particularly conscious. Put it on an index card, put it in your wallet, put it in your phone. We dig through people's phones and pocketbooks all the time that come into the emergency department unconscious. Now, there's been a lot of conversation about people who go to the emergency department over and over and over again. So one is that if you are dissatisfied with your care in the emergency department, you can ask to speak to a patient advocate. You can ask to speak to the administrator on call. And so these are things that you can ask for at the hospital in real time. If you don't agree with your care and you get discharged, I know someone talked about going to another emergency department. Go on to another emergency department. I can tell you that when we do have people for a number of different reasons who come to the emergency department more than once, and we will often order more tests the second time, look a little bit deeper the second or third time. The other thing to remember is that this is a spectrum, right? Some people present very, very early in their disease, and they haven't maybe necessarily met the criteria for being admitted or being in observation. Other people present very late in their disease. Other people, the period between early and late is very short, right? So these are all things that sort of matter and sort of make a difference. The other thing that is important is if you're discharged from the emergency department, be clear, you're always given precautions. What do you need to look for? If I get into trouble, what things would I be most likely to see? That will be on your discharge instructions. How do I know if things are worsening, or how do I know if things are getting better? Make sure to have those conversations with the nurse and the physician in the emergency department, so that way you're aware of what you should be looking for, because those things are very important. When should you follow up with your OBGYN doctor? There are a lot of times when patients follow up with their OBGYN doctor and then never tell them they were in the emergency department, right? So make sure to tell them you were in the emergency department. You may have had testing there, right? So that way they can actually look at that testing. Lastly, I was just going to talk a little bit about domestic violence. The person before me, Ms. Jefferson, did a great job. Please answer that question honestly. Do you feel safe in your home is a question that we ask almost everyone. It doesn't matter. We ask men if they feel safe in their home. It doesn't matter if you come in with an ankle sprain or chest pain. In my emergency department, we ask absolutely everyone that. And then lastly, just a call to action here. Just make, what we really need is we need humane laws around maternal health that keep the government out of making medical decisions, right? We need for women to have a personal, private, HIPAA-compliant relationship with their OBGYN doctors, right? That they can actually make decisions that work for them. The government does not need to be involved in this type of decision-making. And then lastly, really vote and actually talk to representatives about reimbursement equity, so that way we can all have health care, primary care, and OBGYN care in all of our neighborhoods. And that's all I have.
That was a lot. Thank you so much. Excellent, excellent. I truly believe everything you said. Knowledge is power and it empowers, right?
Yeah.
Have a plan, know your rights. So yes, thank you. That's how we advocate. That's how we get out there and we do what we have to do for us, for our sisters. It's about raising our voices. This is how you do it. These are steps. I hope that our audience today is listening and taking notes, because these are the actual steps that you can use to get out there and start the changes, start that transformation in maternal health care. So yes, thank you so much for that. We applaud you for that. Thank you. All right. So when it comes to patient experiences, our next guests are going to be talking about patient experiences as a catalyst for change. The thing is, like you guys have been saying, all of our panelists have been really on point with this. When you see something, say something. When you see something, do something, right? So now we will have two ladies who are going to be coming forth to talk to us about those experiences from a patient's point of view, how they put their pain into a passion and to a purpose. So with that, we're going to have Shakima Kima-Toze, and she is a licensed clinical social worker, a military veteran, a writer, but she is also a bereaved mom, preeclampsia and stillbirth survivor. Her son, Jackson, died in 2017, and after that, she dedicated herself to supporting BIPOC families impacted by pregnancy and infant loss. She and a group of bereaved moms in her state were instrumental in passing the Certificate of Birth Resulting in Stillbirth legislation that became law in 2021. She is driven by the belief that everyone deserves high-quality maternal health care. I'll say that one more time. Everyone deserves high-quality maternal health care. I'm also pleased to say that she is a member of the Preeclampsia Foundation Patient Advisory Council and a Take 10 for Preeclampsia Research Ambassador. So she will be speaking, and then we will have Wanda Irving, who is the co-founder and board president of Dr. Shallon's Maternal Action Project Incorporated. She will be speaking after that, and I'll give you some more information on Miss Wanda after we hear from Ms. Toze.
Thank you so much, Rolanda, for that amazing introduction. And thank you, everyone. This has just been an honor to just be a part of this esteemed panel and to be speaking with you all today. you know, my son Jackson would be 6 years old next month. And just thinking about where I was 6 years ago to where I am today it's just transformational. And I have to thank the Take 10 Ambassador Program, Mama's Voices, and also being a patient family partner, and on the Preeclampsia Foundation's advocacy panel. So when I lost my son Jackson, before that, he was actually my angel baby. And I had experienced fibroids, which, you know, impacts Black women more than others. And I also experienced infertility. And so he was definitely a child that we longed for. And so when I experienced preeclampsia symptoms, I was 7.5 months pregnant. I live in Washington State, by the way, so I don't live in a predominantly community of color. And so representation really does matter. I would see providers that didn't look like me, and I would have to share my experience, what I was going through, my symptoms. And a lot of times I was turned away, like someone mentioned earlier, Dr. V mentioned, sent home with blood pressures 200 over 100 sometimes. And it was my first pregnancy. No one else in my family had preeclampsia. I was away from home, far away. I'm from New York City originally. And so I felt really alone, and I felt unheard and unseen. And through that experience, I knew that I could not continue to be the only one with this story. And I had to let someone know, and I had to use what happened to me to really help other women. So I became so involved in my community. I created a BIPOC maternal health care Bill of Rights. And, you know, it's been said on this panel already, know your rights. Know that you have a right to a second opinion. You have a right to have your family members in the same hospital room with you, advocating with you. I know COVID has made that really difficult, but you have the right. And I think that came out of me not having a sense of who I was in terms of my voice at that time. I was very vulnerable. And from that experience, you know, as a clinical social worker, I always like to highlight the mental health pieces to that, because from that, from losing my son, I experienced PTSD and depression. And so we don't often talk about not only the preeclampsia and, you know, I had a placenta abruption and all the things, you know, the healthcare things, but there's also a mental health piece to this that a lot of times gets missed. And so, you know, women really do need to have that follow-up wraparound care. I didn't know anything about a doula until after I lost my son. I didn't know anything about the maternal health care crisis affecting Black women until afterwards. And so that's not okay. It's not acceptable. We really need to be having these conversations. We really need to be talking to our sisters about their rights, what their power, knowing who they are and using their voice for change. And so this platform has really provided that for me. And it's been in my, you know, my destiny to make sure that no one else has to experience a stillbirth or has to be turned away from you know, a hospital, knowing that it's scary and you know your body, and that you know, you need more help than what your providers are telling you need. And maybe you don't know the language to say or how to phrase things. I remember being asked how much pain I'm in, and I'm like, I don't know. My numbers are low, but I know something's wrong. And that shouldn't be the barometer for you getting quality care. And so, you know, if anything, this has led me to want to be more involved in policy work and more involved in advocating for systematic changes that help women like me and their families never have to experience this again. So that's a little bit about me. I'm so honored to be here. Thank you.
Thank you so much for being here, and thank you for raising your voice. We appreciate you being a Take 10 ambassador, reaching out to other women and expressing to them that by telling their stories, they could be changing someone else's story. So we thank you for that. All right. When we started, Dr. Graves made a point during her presentation to talk about maternal mortality versus Black maternal mortality. And one thing that she said really struck me, it stuck out when she said Black women with a college degree are 5 times more likely to die than white women. With a college degree are 5 times more likely to die than white women. I say that because the next person who's going to be speaking, Wanda Irving, the way that she came to this, the way that she came to become an advocate really started with her daughter. And her daughter had a PhD. Her daughter was an epidemiologist for the CDC. And yet, unfortunately, she passed away due to postpartum preeclampsia. So to tell her story, because she turned her pain into purpose by establishing the Dr. Shallon Maternal Action Project. But in addition to that, she is a very vocal advocate for maternal equity, for racial equity, and when it comes to maternal health care. And so I now give you Wanda Irving, Miss Irving.
Thank you so much, Rolanda, for that introduction. I just wanted to add something to what you said. Black women with a college degree are 5 times more likely to die than white women. But what you didn't mention is that's white women with a high school education. So it's not even white women with a college education, it's white women with a high school degree. And I think it may not even be the fact that they've completed high school. So that's a really sobering statistic. And I'm sorry?
I say yes, ma'am. Yeah, wow, I'm blown away with that.
And my daughter was an amazing woman. She had not only a PhD, she had a dual PhD in sociology and gerontology. She was considered by her colleagues as a brilliant scientist at the CDC, and she was known to be a fierce champion of health equity and equality for women, especially women of color. And the saddest part is that the disparities that she fought so hard to end for Black women cost her life 3 weeks after giving birth to her only child. And to have her death be totally preventable, as were 89% of maternal deaths from 2018 to 2020 in Georgia, according to the Department of Health. That is something, it's hard to live with. My daughter was, as I said, an amazing woman, but she what would I say? I guess she challenged the conventional wisdom. Next slide, please. She challenged the conventional wisdom, which blamed the patient and said they were uneducated, uncompliant, obese, made poor health choices. And that was not Shalon. Shalon did not meet that stereotype. She was well-informed, highly educated, extremely articulate, and compliant, yet she still fell victim to maternal mortality. Next slide, please. It was mentioned a lot that women are not heard. Black women especially are not heard. They are not believed. They are not respected. I don't remember if it was Dr. Graves or one of the other speakers who said that this is something that's been going on since we came over here from Africa. It has not been something that's just new, and it has been the case. And I think a lot of it was started because of J. Marion Sims and his experiments, and that kind of training went into medical school curriculums. And so a lot of the stereotypes were passed on as Black women are more likely to, or more, they're stronger and they can take a lot of pain. And I think that's one of the reasons why a lot of doctors don't believe when we say we're in pain. And I know that was the case with my daughter. And it happens at a time when women are most vulnerable. I watched my daughter fight to have doctors hear her and take her seriously, instead of those medical professionals dismissing her symptoms as variations on the norm when they were really signs of her impending death. Next slide, please. As Dr. Graves said earlier, we've got to join together and get focused on finding solutions if we want to change the paradigm and move the needle. Because if not us, then who? Advocacy is the key, as well as education. This is your life, and you only get one of them. You got to know your rights. And I think we've said that numerous times. Research your resources, know what's out there. One of the things that we've created was the Believe Her app. I know coming up is going to be the Earth app. Mama Love was talked about. There are plenty of resources out there. And don't be afraid to ask questions of those medical providers until you get answers that you truly understand. And if you feel unsafe with the medical provider at the hospital or the clinic, elevate those concerns to the health safety officer or someone who is in a position to do something for you. I co-founded Dr. Shalon's Maternal Action Project in 2020. That is my way of honoring my daughter. Her philosophy was to see inequity wherever it exists. And she was not afraid to call it by name, and she worked hard to eliminate it and vowed to create a better earth. I think in her time, she did what she could to meet that. And what I think her legacy is that we are picking up that mantle. And there are a lot of people who she either mentored or were colleagues who tell me all the time, we're not going to let her death be in vain. And so that's what, we were about awareness building when we first started in 2020, but now we're focusing on outcomes. We're collaborating with like-minded organizations, and we are taking actions that we feel will lead to healthier outcomes for Black women in the future. And as I said, we founded the Believe Her app. We actually won the 2022 Microsoft Hackathon. And as a result of that, we've gotten Microsoft behind us as a partner, and we're working with them to add artificial intelligence to the app. And we're really excited about that as we move it forward. We've co-founded the first annual Postpartum Awareness Week, in which we built a coalition of over 70 national organizations to plan, coordinate, and implement that week in April of 2023. We're delving now into research as co-investigators with Dr. Natalie Hernandez of the Morehouse School of Medicine Maternal Health Equity Center. We're partnering with Dr. Karen Scott on her CATCH pilot project. And we've got other initiatives coming out in 2024, among them one with Sutter Health in California and Henry Ford in Michigan. We're really excited about the work that we're doing, and we're always open to creating we're always open to connecting, creating, and collaborating with folks and moving things forward. That's what we've got to do, and we've got to do it together, because one organization, one purpose, one whatever is not going to do it. It's going to take all of us, and we've got to work together. We've got to get rid of these silos and this fight for one little sliver of the pie. We've got to come together. There's no other answer for it. Otherwise, we're going to be in this position for years to come. And children, communities, society is suffering, and it's going to be up to us to make the difference. Thank you so much for having me here today. I could go on, but time is short. So thank you again.
Well, thank you so much, Ms. Wanda. You really are the epitome of turning your pain into purpose. And I know that with everything that you're doing, you are changing the world. You really are. And you're making it better for Black women like your daughter, so that we don't have any more. Well, hopefully we'll get to a point where we don't have any more situations where, we talk about a woman who died unnecessarily, in a situation like that. So thank
That's
you for that. And you are absolutely right. It's going to take all of us. We always talk about in our community, I'm going to just be Black and real with y'all right quick, okay? We always talk about in our community how, it takes a village and how we are all, together, but we've got to put action behind our words. We've got to really make that happen, because women are literally dying to have babies. How does that even make sense? It doesn't, right? And that's why I'm happy with how the Preeclampsia Foundation, with the Take 10 for preeclampsia research, basically it's a for us, by us, about us type of an initiative, in that we have Black women who have experienced preeclampsia, some with really adverse effects, how they've come together. And Miss Irvin, you're on that focus group, and you're able to really invest in the initiative and tell people this is where we're going to go. These are the things we need to focus on, because who can talk better to us than ourselves, right? And also, that's why I'm also happy to see apps out there that are being created by Black women, like Earth App. Who better to help us in this journey than ourselves? So with that, I'm going to introduce Ms. Sheridan Blackwell. She is the head of systems change, hospital, and partnerships for the Earth App. She's a seasoned healthcare professional with over 10 years of experience. She leads strategy development and manages each hospital pilot and partnership process. We thank you for coming on, Ms. Blackwell, and telling us more about the Earth App, and really putting things in perspective as to what we can do to help ourselves. So I turn it over to you.
Thank you, Ms. Rolanda, and thank you so much to Ms. Wanda for sharing your daughter's story. My name is Sheridan Blackwell. I'm the head of, I work for the Earth App. I'm the head of hospitals and systems change work. If you haven't heard of the Earth App, we are a Yelp-like platform for Black and Brown women to leave reviews of their birthing experiences in hospitals, as well as their experiences with OBGYNs and pediatricians. Our goal is to really serve and understand what the most significant issue is within this healthcare industry, which is bias and racism in healthcare. We've gone through the stats already tonight. We do know that Black women in this country are 2 to 3 times more likely to die than white women from childbirth and childbirth-related effects. I'm actually from New Jersey. Our rates are actually 7 times, and my bordering state of New York and New York City is between 9 and 11 times. So when we think about the current approaches that are in play, our goals are really to come up with a new approach, because what we have been doing for so long is not working and not working fast enough. We have anti-bias trainings for providers that are being implemented, but we're really not going back in to check in with the patients to understand what their experience is after going through this, right? So these really do become train and pray situations, or tick the box exercises that we can say we did this, right? We also have evidence-based research, but evidence-based on whom? We know that we were not included in this research. Black and brown women were not included. How are we going to use this evidence base to approach this issue? So the goal at the Earth App is really to create a new evidence base filled with the voices of us, filled with the voices of the community. We do not believe that maternal mortality review boards, which are very important, but they really only analyze from the grave, right? We really do not want to only focus on that death and that mortality, but understanding what is the goal, what happened during your experience, and really looking to make a 5-star experience for all of us that we deserve when we go into hospitals to deliver. So our goal is to really help hospitals, payers, and providers learn from the living, okay? And that is done through our app, which is spelled like the word birth, but we drop the B for bias. Again, we are a review and recommendation platform. for Black and brown women to lead reviews of their OBGYNs, their birthing hospitals, and pediatricians. What we do on the back end is turn all of those surveys into experience data, both on the qualitative and quantitative side, so we can work directly with hospitals and providers to address what their blind spots are. And these are things that they're not even aware of because there's no way to currently measure it. A lot of these things right now, these stories, are kind of word of mouth. But as one of our Earth ambassadors said today on our Instagram channel, put your trauma on paper. We have to document these things and we have to put them in a centralized database because it's so easy for facilities to dismiss our stories as one-off. So that just happened one time, right? We're not seeing these trends as you see. We haven't had any maternal deaths at this hospital, as if that is the goal. Our goal is to have a 5-star experience when we are delivering across the system. And so our goals are really to detect those trends and bias and then reward providers and then work with providers that need some help. And then understanding what those best practices are really to create a better experience. So we do have a structured review process. We have 4 review types, as I mentioned: prenatal experiences, when you're pregnant, come back again, tell us about your birthing experience in the hospital. That is our longest track, but it does ask specific questions about your experience with the providers, physicians, and midwives, as well as nursing and lactation. As we know, there are a lot of breastfeeding disparities for Black and brown women. We ask patients to come back again and tell us about your postpartum experience after you've been discharged from the hospital, and then to come back again once more and tell us about your pediatric appointment up until baby's first birthday. And we're really excited that we not only accept reviews from mothers and birthing individuals, but also from fathers and partners, as we know that Black fathers, when they're going into the hospitals, are facing some of the same difficulties when they're going in to support their partners, being threatened with security for asking questions or being seen as violent just for speaking up. We also accept reviews from doulas, which are critically important to our Earth ecosystem, as we know that doulas are the neighborhood watch for maternity care, and they can really advise us on, number one, how they were treated as hospitals are working to become more doula friendly, sometimes on paper, and really understanding what their clients are experiencing during their birth. And we also take reviews from hospital-based midwives. You are able to search the reviews that are currently in the Earth app. All reviews are transparent. They are anonymized, but you are able to search the reviews by either your zip code, your city, your state, or the physician or hospital name. We're currently available in English and Spanish in the app, and then Haitian Creole on our Earth app website. One of the things I love about Earth is we're really looking to decode what bias is. My background before joining Earth is working within hospital systems. I was an administrative director of a women's health service line. And in my experience, we kind of talk about bias just as this notion, right? But it's really hard for providers to understand what they are contributing to this bias if they don't know what those direct specific behaviors are. So we like to get right to the point in asking, like, did you experience any of the following during your birth? Was it something as nuanced as a lack of eye contact? Do you feel like they dismissed your pain levels? Were there comments that were made based on racial stereotypes? Not so we can understand not just what happened, but how it happened, and then work on the back end with these hospitals and providers to show them the frequency and patterns. So we can't dismiss them as a one-off if we're seeing this in great numbers, especially over a period of time. Across our national database right now, we have about 10,000 reviews, but I just wanted you all to see what our top attitudes that are being experienced in hospital. With number one, my requests for help were ignored or refused. Number two, my pain levels were dismissed. And these for me are big red flags, like red flag alert. If we know that most of these maternal death stories that are happening in hospital is related to someone's requests not being acknowledged or their pain levels being dismissed, as we've heard a lot tonight. Number three, I was scolded, yelled at, or threatened. A lot of comments from patients advising on what type of testing they do want for themselves or that they do not want for themselves, and then being threatened with other authorities like CPS and security when raising these questions. Number four, my physical privacy was violated. And then number five, assumptions based on racial stereotypes. And when I say racial stereotypes, I'm not talking about, tiki torches or anything that's out there in your face. But I constantly see comments on, nurses commenting on the complexion of the baby's skin in comparison to the father or the mother. We see comments on nursings referring to the patient's, I would say the mother's partner as Mr. Baby Daddy, because that is a common thing that we hear. So we're really looking to understand what type of racial stereotypes and all these things that are happening within the birthing process so we can work with hospitals to approve this. So across what we do with our data is really to drive systems change, and we do system change on a number of different levels. We work directly with hospitals in our hospital pilot partnerships, which is where we work with them over an 18-month to 2-year process, really working to dig into their community. We're collecting reviews directly from their patients. And then on the back end, we're working with the hospitals to co-create improvement plans and implement those plans. We really believe this accountability on the hospital system will be driven by the transparency in the apps. As we know, hospitals are at this point businesses. And the more that we create and share our experiences, that will impact their bottom line. If we're seeing a lot of negative things coming up, they cannot ignore that. And the fact that it is transparent and public is only what's going to push this forward. We also work with city and state collaboratives. We're working with the New York City Department of Health. In the Bay Area out in California, we're contracted with 2 public health departments, and we're really using Earth as an independent, community-centered provider of Black experience patient data, which is a lot of things that hospitals are not able to capture because of the earned distrust between communities of color and their hospitals. And we're also in a few conversations with some insurance companies and payers, and our goals are really to publish. Once we grow our database larger, we would really love to acknowledge those leaders and those laggards and spark that race to the top. Again, our whole system is about accountability and transparency. Our founder is Kimberly Seals-Allers. Her favorite quote is, "Whatever the question, the answer is in the community." And so our goals are really to share our stories, both positive and negative, so we can influence where we go for care, and be able to inform our own communities of what good and bad care looks like. Thank you.
That is awesome. I really feel like you're bridging the gap there, right? You're providing that voice that a lot of people are missing, and that knowledge as well. So thank you. We really appreciate it. And please tell your founder we look forward to just seeing your hospital pilot programs expand, and this becomes something that pretty much is fully integrated in most, at least major hospitals, something that our patients can actually use. One question that did come to you from Eleni Zigas, who's on, and she is, by the way, the president and, the CEO of the Preeclampsia Foundation. She asked, do you have enough data from specific states that you can break down the data geographically?
Yes, we do. So Kimberly Seals-Allers did a lot of her initial work for the Earth app and a lot of her testing in a few key cities. So Sacramento, New Orleans, New York City, Philadelphia are areas where we do have much of our data and are able to really spread some of that out. But our goals right now are really to increase our database so we can have enough to really publish. And our goals are to get all that information back out into the community so they know that we're doing something with their data and their stories. It is really, I think, a lot to sometimes share their stories again. A lot of them are traumatic. And our goals, again, are really to use this to inform each other of where we should and should not go.
Excellent. What about, are there any plans for you guys to expand to like more urban or even suburban areas that don't necessarily have like major hospitals there, and care maybe miles away?
Yes, so the Earth app is available. Anyone with a cell phone, whether you have a iPhone or a Android, you're able to download it. It is free. And we do not have to be partnered with a specific hospital for you to leave a review. So you can leave a review of any physician, any midwife, any hospital, and you can share that with us. And we would really love if you could. Again, our goals are to grow our database this year, so we are too big to ignore.
Excellent. Miss Jefferson has her hand up.
I just want to thank the presenter for that, all the information that she has provided and for providing that app. Some of the things that she said about the top attitudes experience, as several of the presenters have stated, ignored or refused requests for help. Pain levels were dismissed. Scolded, yelled at, or threatened. And this happens with more so with women who are underinsured or uninsured. Physical privacy was violated. Assumptions based on racial stereotypes.
Mm-hmm.
As this webinar deals with advocacy, yes, we want to advocate for these mothers of color who are being mistreated for one reason or another. But also, I have been talking to Attorney Ben Crump about this because I see the levels have increased as far as the maternal deaths and infant deaths. So we are very concerned about this. As I stated previously, in the case that the fetus who was 38 weeks and expired because of stillbirth, mother went to the emergency room and to her doctor at least 5 times, had preeclampsia, but was sent back home each time, and the last time, the 5th time, the baby was dead and almost the mother died. So we are very concerned about this. And yes, we don't file a lawsuit on every case, but some cases you got to get their attention. And when you hit them in the pocket, you get their attention. So that's what we have been looking at. So I just want to say thank you for bringing that, your presentation.
And
Yes.
Rolanda, if I could just sort of interject here.
Please do.
Sisters, what we need is power, okay? We need power. We need to have authority, access, decision-making, budget, money. And the way, as we come into these elections in 2024, we need to get on the ball and make sure that whoever is elected appoints some of these brilliant women to positions of power. I served in the Department of Health and Human Services for 5 years, and I've seen firsthand, you have power when you have the budget over CDC, when you have the power over the National Institutes of Health, the Office of Minority Health. So for all of these brilliant speakers today, get involved in politics. Our community kind of says, I don't want to do that. No, we have got to get power. And in this country, having access and knowledge of governors, presidents, senators, mayors, people who appoint people. This was fabulous. Thank you very much for your outstanding education, your information, your knowledge, your vision. I'm proud of all of you. Now I want to see you all in positions of power.
Thank you. Thank you. All right. I saw Dr.
May I say one more thing?
Okay.
Carthenia Jefferson, as Dr. Myers has stated, get in position of power, advocate, but vote, and encourage others to vote. Because as one presenter said, these men or the government making decisions for us over our bodies, especially in the Southeast. I don't know about in your particular area. That is a problem. So we have got to vote, pay attention to the issues, especially when it comes to our issues. Vote, encourage others to vote and take action.
All I got to say, Ms. Jefferson, is that I am in Florida. So that should tell you a lot. That's all I got to say. All right, Dr. B, you had your hand raised.
Yes, I have my hand raised because I just wanted to, I think it was Carthenia Jefferson who was talking about getting the hospital's attention. She was specifically talking about it in reference to lawsuits. But I just want to also bring up the fact that many hospitals, including my hospital, are Press Ganey hospitals. And we send out customer service surveys, right? And those customer service surveys, we are actually ranked and benchmarked against other hospitals. And when those surveys are higher, we get a higher reimbursement rate, okay? So fill out those surveys. If you feel like your care was disrespectful, or the doctor or the nurse was using racial stereotypes to deal with you, put it in there. Because trust me, they actually send that to me as a director, and I have to respond. I have to speak to the providers that are involved. And that usually happens faster than a lawsuit. The other thing is, if you wind up going to an emergency department more than once, some people don't go because they're concerned about the copay. If it takes 2 or 3 emergency department visits for us to actually diagnose you, please write and ask them to waive the copay. We do it all the time, okay? We do it all the time because we look back at the chart and we say, this person came 2 or 3 times. They should not have to pay for 2 or 3 emergency department visits. Send a letter, ask for the copay to be raised. I can tell you myself, I waive them 100% of the time if someone legitimately had to come back 2 or 3 times before there was a diagnosis. So it doesn't happen often, but it does happen sometimes. So I just want to bring up those 2 things about the Press Ganey scores and also writing the letter to get your copay waived.
Excellent, excellent. Ms. Jefferson, did you have any final thoughts, or did you have your hand up? I apologize.
I did not have my my hand up,
Oh,
but
okay.
as the director said, make sure you try to seek some actions with the hospital representative. And also, if you think you have been seriously injured or harmed, like I said, take action. And also, as Dr. Myers said, please advocate and vote.
Yes.
And run for some of these positions as well.
Amen to that. All right. Also, the last voice we'll hear before we wrap up is Dr. Graves. I see
One
you
other thing I want to point out is that when you go to the emergency room, their criteria, especially for the diagnosis and management of high blood pressure, is different than it is for pregnant women. So you need to let them know that you're pregnant, and you need to know what what the value should be. And it happens even in a hospital that delivers 10% of the babies in Tennessee. Our emergency room kept someone, and then the head of the emergency room had the nerve to send me their criteria for managing blood pressure. So I sent them back our criteria for managing blood pressure and why they should have sent that patient on up to our OB emergency area. So know that it is different. Our number is 160, top number over 110. And a lot of emergency rooms won't treat to 180, thereby with some of the issues, resulting in some of the issues that we see in maternal morbidity and mortality. Just want to put that out when you're going to emergency room, that our values are different. You need to be aware that our values are different. And so do not leave, say, I'm not leaving, I need to see, especially if they have an obstetrician or someone who provides obstetrical care like a midwife, I need to see an obstetrical provider before you let me leave this emergency area.
Excellent, excellent. So all of this, raise your voice. We all have that power to raise our voices and let our concerns be known. So thank you to everyone who's been on the panelists. If you see the post-event poll is up now, please go ahead and fill that out. If you could, it helps us engaging the event and knowing what we should do next. And we are going to be doing some other events, so just stay tuned for that. In addition to that, I want to thank the Black Women for Positive Change for partnering with us and for really championing this event, this webinar, because they really are focusing on a culture of nonviolence, trying to transform the way that we do things. And part of that is being an advocate, right? Part of that is actually being able to have our voices heard. So just to let you know, they are going to have more events this month. And if you go to the blackwomenforpositivechange.org, you can see it there, or you can go to Month of Nonviolence. Yeah, the Month of Nonviolence.org page, and it also has a list of the upcoming events that are going to be happening. I believe the next one is on the 21st, this coming Saturday, where they're going to have one dealing with Black fatherhood. So that should be very cool too. In addition to that, go ahead.
Oh, thank you for putting this up. If you could put it up on Month of Nonviolence and click events, that will give more specific information, whoever's putting this up. Go to Month of Nonviolence and click on events.
Yeah, monthofnonviolence.org, right?
There you go. And then click on events up here at the top. Yeah.
There we go.
Thank you.
Yeah, and so by going to this page, you will see some other events that they have that is championing the Month of Nonviolence. So we thank you for that. In addition to that, I heard several people talking about, really getting involved in terms of raising their voices when it comes to preeclampsia and some of the other maternal health complications things that go with maternal health. And so we invite you at the Preeclampsia Foundation to check out our page, which is the preeclampsia.org/take10, and that's take 10. And on that page, you will see information about the Take 10 for Preeclampsia Research Initiative. We are determined to get as many women registered as possible. It only takes 10 minutes to register. And we want to be able to share your stories with researchers who may find some type of correlation between different stories and different aspects of your experiences. In addition to that, if you want to go further, the registry allows you to get even more involved in that. But the whole point is being able to share your experience, and don't think that you should keep it to yourself, but share it so that other women, other people can actually benefit from and learn from what you've experienced. Like I said, our slogan is, your story can change hers. And that's what we believe. And even tonight with this whole seminar, your stories, every one of the panelists, everything you said can change lives. And so we appreciate you. We thank you. I just want to say with my presenters, if you guys have information that we can put on the Take 10 webpage, please send it to me, send it to Lainey, and we will get it up there, because it's all about, advocacy, giving people their voice. You guys gave so many steps tonight that we can take towards, better ways to treat ourselves and to help with our those of us who are dealing with Black maternal health. So thank you again for that. Give yourselves a hand first off. Am I the only one giving a hand? I know y'all ain't gonna leave me hanging. Thank you very much. And I hope that our audience really enjoyed this and benefited from it. So thank you again. And I apologize that we went over, but it was good information. And when you have good information coming, sometimes you chewing on some good stuff, you don't want to let that go. So I appreciate all of you guys being here tonight. All right.
Thank you, Rolanda. Thank you for your excellent moderator position and introductions, and you handled it all beautifully. Thank you.
I was trying to take notes too. I'm like, oh man, this is some good stuff. So thank you guys. And I pray that you all have a great night. And I pray that we all stay in touch in some way, because it's going to take a village. And right here, we have that village. I would say look on the Black Women for Positive Change website, see the things that they're doing. They have many initiatives. They have 5 thrusts, I believe, right now, dealing with nonviolence, with families. Dr. Myers, what are some of the other things you're dealing with?
Voting rights and opportunities as alternatives to violence. And this group could create a Black Maternal Health Political Action Committee.
Yeah.
And put the pressure on these politicians, because really, unfortunately, they all respond to money. They all respond to pressure. And the kinds of issues that we're talking about tonight simply have to be integrated into the health system. Yes. Over $2 trillion is spent on health, 2.9 trillion every year. Now, we should be getting a huge percentage of that for the issues that were raised tonight. But they're not going to give it to us. Ain't nobody coming and knocking on any door saying, ladies, would you like to have this? No, we have to organize, demand it, and go for it. And Dr. V, she's been working on this. We work on it together with Black Women for Positive Change, but form a political action committee. Think about that for 2024 and get the visibility out here. I love Earth. I love the things that you guys are doing, all of you. But it doesn't matter if it's too quiet. We've got to be in their face.
Well, after tonight, I believe we're going to hear some more voices be raised. So I think that everybody has tools now to raise their voices. Let's go forward and do that. All right. Well, if all hearts and minds are clear, as they would say, then thank you guys so much again. And may you have a blessed night, blessed week, and we will be seeing you soon, I hope. Take care.